So let's look at letrozole. Let's look at the extended letrozole regimens in polycystic ovaries. If you want any of these references, I can load them later on. And if you So what are we looking at? We're looking at in resistant PCOS, where letrozole for 5 days at 5 milligram from day 2 to day 6 does not work. Can we try and improve the chances of pregnancy and chances of ovulation in the same way? So the traditional limitations are that often in resistant PCOS, letrozole given over 5 days does not work, and we're looking for alternatives, including gonadotropin injections. All these are evidence-based solutions, and we're looking at can we reach that 92% ovulation rate that can be maintained. So if you look at, again, remember one thing, the evidence is less because the number of studies done in extended doses is limited. So if you give 5 milligram for 7 days, we think that ovulation rate reaches about 70%, clinical pregnancy rate reaches about 31%, and live birth rate of around 24%. So that's decent and doing as well as Clomid or probably better than clomiphene. Now, if you decide to give it for 10 days, so you extend the treatment window, provides a longer exposure to medication. So what's it doing? It's giving you a peak of FSH, which is much higher, and that too for a longer time. And ovulation rate increases to 76.8%. And that's again, and superior to a standard 2.5 milligram regime. With the two-step regime, which means initial 7 days, and if there's no response, then extended to 10-day regime and continuing 5 milligram for a further 5 days, showed a success rate of ovulation to 92.7%, which means that you had a look on day 8, nothing grew. And then you increase the dose for another 3 days. So if you look at all the data which is coming up on these extended courses, the 7.5 milligram for 5 days, comparable pregnancy rates for 5 milligram for 10 days, and produces more mature follicles when used with adjuvant FSH, again with a risk of multiple pregnancies, and consider patients giving them a higher dose but for a shorter duration. If it gives 7.5 milligram for 10 days, the ovulation rate increases. Again, sometimes this has been combined with dexamethasone. I don't use it in my practice. It's beneficial in highly resistant cases, and consider this as the final approach if you're not going for gonadotropins. What are the adjuvant therapy? Decreasing insulin resistance by using dexamethasone is one option. Again, I don't use it. FSH supplementation is something which is reasonable, and increasing it by pushing the ovaries harder, and consider for patients proceeding using this for failed cycles. So when you look at the extended duration, the 7 to 10 day protocols show a higher effectiveness, and they look at producing more ovulation, though higher risk of multiple follicles. 5 milligram appears sufficient for almost a large majority of patients, and the individual approach needs to be considered. Stepwise sequential also maximizes the chance of ovulation happening. So in cases where you see a very resistant ovary not responding, you can look at either extending the dose for 7 days or 10 days, or adding adjuvants at FSH. My experience with dexamethasone is not very good, and I don't use it. So if you've used it, give it a try and see. The risk is that there may be multiple follicles growing, and you may need to then decide that we may need to stop the treatment to avoid overstimulation. Thank you.